Thank you, Gail. I'm Sasha Pearl from the University of Pennsylvania. I will be giving a talk today on the role of FLT3 mutations in AML. And these are the learning objectives for the talk. We are going to get into diagnostics, prognostics, a little bit about the function of FLT3, the role of targeted therapeutics, both in frontline and relapse refractory patients, and how the role of transplant may be changing. So let's dive right in with diagnosis and approach to initial therapy for patients with FLT3 mutations. Just to introduce the topic itself, FLT3 is a receptor tyrosine kinase. It's one of the most commonly mutated genes in AML. It normally regulates hematopoiesis, is expressed on immature hematopoietic cells in the marrow, and it's very commonly mutated in AML and is associated with a few clinical features you should be aware of, including marked leukocytosis in a substantial number of patients, a high marrow-blast percent, often very proliferative disease that has a fast doubling rate, and genetically it associates with typically intermediate risk karyotype, often NPM1 mutation. It can be seen in other settings such as T69. It commonly occurs in APL, but it's not actually prognostic there. There's two major kinds of mutations in FLT3, and both of them lead to activation of the kinase. They occur in different parts of the gene and the protein itself. I've shown that on the cartoon on the left. In the juxtamembrane region, there are internal tandem duplications that insert FLT3 sequence, lengthening a region of the protein that is an auto-inhibitory domain, and thus the kinase stays on. There can also be point mutations in the activation loop of the tyrosine kinase domain, and that can lead to activation of the kinase as well. Importantly, either mutation can predict response to FLT3 inhibitors, but certain drugs will only be active against the FLT3 ITD mutations and not TKDs. We detect these mutations by two major methods in the laboratory. The first is PCR, which historically was the first test to be developed and brought to the clinic. This is generally a rapid turnaround test. Often we can get results in just a few days. It's reasonably good sensitivity, can pick up one mutated cell amongst about 100 normal cells. It potentially misses very large internal tandem duplications. But the useful thing about this is that it's a quick and easy test. It can be run without much sophistication. You get an answer fast, and it's generally pretty robust from lab to lab. Additionally, early on, it was noted that patients who had a high allele burden of FLT3, and this was expressed by the ratio of FLT3 ITD to wild-type FLT3, had a more aggressive course, a higher relapse rate, and worse survival. So the allelic ratio of FLT3 ITD to wild type became established as a prognostic marker. Now, one challenge is this is not always reported from labs, and there's not a standardization of this across labs. So you can't use results from one lab as a standard worldwide, despite the fact that the ELN and NCCN do recommend using these allelic ratios to make transplant decisions. So it's complicated when you want to use that clinically. It's robust in general when there's a high ratio. It's just harder when it's very low. In terms of the other tests that can be done, next generation sequencing is commonly employed in sequencing panels for AML mutations. And the good news here is there are mutations you might only pick up by next generation sequencing if they do not occur in the hotspots for mutations that are picked up by PCR. That being said, a challenge with next generation sequencing is that it's slow. You can, again, miss large insertions, and it's not very quantitative. So you can't use next-generation sequencing to get an allelic ratio and to really tell what the allele burden is here. It's not a linear predictor of how much FLT3 mutation is present. Again, it's helpful when all you see is mutation and there's no wild type, but it's not very useful when there's a low allele burden for two reasons. One is you could miss the sequence that's mutated and it's just not picked up by the assay, and or it's just not quantified in a linear fashion. So I do not recommend using next generation sequencing to look at an allele burden to make a transplant decision. Okay, with that out of the way, where do we see FLT3 mutations? Well, again, they typically will show up in about a quarter of patients, anywhere from 25 to 35% of patients, a little bit more frequent in younger patients than older patients, and in patients with de novo AML, rather than secondary AMLs arising from MDS. Although if you have a patient who has MDS and suddenly their white count just shoots up as they transform to AML, that's not a bad story for a FLT3 mutation acquired at transformation. There's a known association with mutations in NPM1 and DNMT3A, or both of these mutations, which may have a role prognostically that I'll show in a minute. And it's uncommon to see them in patients who have complex karyotype. Not impossible, but uncommon. So they don't tend to dance together with P53 mutations, thankfully. In terms of therapeutic approach, in general, we lump patients with AML into those eligible for intensive therapy, largely based on a fitness assessment rather than a strict age criterion. Although the FDA has recommended using an upper age of 75 for intensive trials, obviously the decision is yours as a physician to decide who you want to treat intensively. But if you are going to treat patients intensively, FLT3 mutated patients really do fit into their own group, and treatment approaches are separate for other groups, as just shown here on this diagram. For patients ineligible for intensive chemotherapy, it's really dealer's choice as to what's best. And I'll present some data on non-FLT3 targeted therapy in this area, which I think actually there's the largest evidence base for using at present. It's been known for some time that the different types of FLT3 mutations have different prognostic effects, with patients showing a tyrosine kinase domain mutation at D835, again, in the activation loop, having a similar prognosis to patients who don't have a FLT3 mutation, and patients with FLT3 ITD mutation having worse outcomes. This is an old study. It's almost 20 years old, and it comes from data from the AMLSG cooperative group in Germany. And on this study, patients received 7 and 3 for up to 2 cycles and 4 cycles of high-dose cytarabine consolidation, and generally did not go to transplant. And this is kind of the natural history of treating FLT3 ITD positive AML with chemotherapy only. And as you can see, the outcome is considerably inferior to the patients who have TKD mutations or wild-type FLT3. And this is one of the reasons that we've recommended, in general, moving these patients to transplant in first remission, and I'll show data to support that in a minute. The ELN more recently has taken a little bit more nuanced approach now that there's more known about cooperating mutations. And co-mutations in NPM1, as well as variations in the allele burden of FLT3 ITD, will modulate the risk profile of a patient with a FLT3 ITD mutation. So as you can see from the right, the ELN makes up favorable, intermediate, and adverse risk groups in AML. And there are patients who have FLT3 mutations in all 3 risk groups. So you can't use the presence or absence of FLT3 ITD alone to say a patient is adverse risk or favorable risk. You need the whole complement of genetics to say. And there are patients who have a relatively better course, typically patients with NPM1 mutation and a low FLT3 ITD allele burden by PCR again. And the challenging thing here again is that there's not a uniform test worldwide that says this is the standardized test that we use to make that determination. So buyer beware when using allelic ratio to make a transplant decision. I'm very cautious of that because of this in terms of the lack of standardization. But the patients really at high risk are those who lack NPM1 and who have a high FLT3 ITD allelic ratio. Now, I mentioned that DNMT3A mutation is commonly co-mutated with FLT3 ITD, and this tends to be associated with worse prognosis, and it renders the effect of NPM1 largely dispensable. It no longer makes those patients into a favorable group if there's the presence of a DNMT3A mutation, particularly substitutions at R82. Those are best validated and shown here from this study from Elie Papio-Emmanuel from the Sanger group, looking at a very large number of patients treated intensively for AML across all age groups and sequenced for a large number of AML-associated mutations. As you can see, the worst prognosis were patients who had DNMT3A mutations and FLT3 ITD mutations, worse than any other permutation of those three commonly mutated genes in AML. And in these patients who had NPM1 mutation and DNMT3A mutation, the FLT3 ITD positive patients did particularly poorly. So watch out for those folks. I send all of those patients to transplant in CR1 who are candidates, regardless of the allelic ratio. Now, if we look at therapies that improve outcome in FLT3 positive AML, we know of three evidence-based approaches here. The first is intensified induction. And high-dose daunorubicin, here using doses of 90 milligrams per meter squared, at least on the first course of induction chemotherapy, has been shown in not one but two studies to improve overall survival, specifically for patients with FLT3 ITD mutation. I've shown data from the ECOG 1900 study, and there's a similar result from the UK NCRI AML 17 trial. And in that study, that was the only subgroup that benefited from the higher dose of daunorubicin on the first course. Earlier data had suggested that allogeneic transplant for patients in remission benefits for patients who have anything other than the most favorable genotypes in AML and a normal karyotype. And here on a donor versus no donor analysis, patients who had anything but favorable genotypes defined at the time by the ELN 2010 classification as those who had FLT3 ITD with or without other mutations. You can see presence of a donor did much better. And on this study, 80% of patients with a donor actually proceeded to transplant. So these data support the idea of using transplant in CR1 for FLT3 ITD positive AML. We have less solid data for FLT3 TKD, and those patients can do reasonably well in the presence of an NPM1 mutation. And most recently, data showed from the ratified prospective study of Mitosorin versus placebo added to frontline chemotherapy for FLT3 mutated patients that patients treated with Mitosorin on that study, randomized to the Mitosorin arm, had a superior survival. And on this trial, the majority of patients went to transplant, 57%. So bear in mind that getting these results may require transplant, although I'll show you some data to say who sees the greatest benefit from transplant in a minute. Now, here are a little bit more granular data from that trial, and here's the study design on the left. Patients were enrolled up to the age of 60, screened for FLT3 mutation. Those who either had ITD or TKD mutations were randomized to standard 7 and 3 using daunorubicin 60 milligrams per meter squared, and a 14-day course of midostaurin delivered on days 8 through 21 during each of up to 2 courses of induction and 4 cycles of consolidation, followed by a year of maintenance. There was a placebo control and patients did not cross over. And as you can see on the right, on the top, the midostaurin arm had a better survival with a benefit being seen in all ELN risk groups. We can see the ELN risk categories here for both arms, and then I'll show on the next slide. Oh, I thought the next slide shows this. On the subsequent slide, what the effect in individual risk groups is. That's shown here. So on the left, the midostaurin arm in red versus the placebo in blue, and the 3 different ELN risk classifications. You can see across the board, midostaurin was associated with better survival. This is overall survival across all the ELN classifications. But interestingly, as I mentioned, transplant was used by the majority of patients on this study. And in the placebo arm, you really needed to get a transplant to do better. As you can see, the transplanted patients on the right in blue on each of the study arms, in the placebo arm did better with transplant, and in the midostaurin arm only did better with transplant in the ELN adverse group. The other subgroups didn't show such a clear benefit. And that's interesting because we have to wonder, why is it that we're seeing so much better transplant outcomes? And the answer may be that we're getting better induction success or early treatment successes through the addition of midostaurin. We don't have MRD data from this trial, but it stands to reason that you may actually establish a deeper remission with adding a FLT3 inhibitor. And what's important about that is that you need to use a test that turns around quickly to know that you need to use midostaurin in induction, because there were many patients on this study who went straight to transplant without any consolidation. If they didn't get midostaurin during induction, they wouldn't see this benefit. And interestingly enough, patients who went to transplant actually did better if they got midostaurin in induction than patients who didn't. And you can sort of see that looking at the two there, but I'll show it more graphically later. Subsequent data have shown that the role of MRD negativity is a strong predictor of relapse in patients who are FLT3 ITD positive. Here's a study on the left from the UK MRC, not using a TKI-based regimen, but just a chemotherapy regimen, and looking specifically at patients who are nucleophosmin co-mutated. Here, looking for NPM1 burden in the peripheral blood. Patients who had detectable NPM1 mutation in the blood after 2 courses of chemotherapy had a very high relapse rate. But interestingly enough, you could be FLT3 ITD positive, MRD negative, and not necessarily have a particularly high relapse rate. So I use this in order to screen patients for a transplant decision if I think they may be in one of the more favorable groups. So ELN favorable, I will look at NPM1 burden to make a transplant decision. I do that in my own practice. Why is this important? Well, if you transplant patients who are MRD positive, the relapse rates are really quite high. We don't have a large study to show this, but a study that looked at MRD levels going into transplant that was blinded to the investigators found that patients who had detectable FLT3 ITD prior to transplant really had very, very poor post-transplant outcomes shown on the right here. And this was with a very sensitive test for FLT3 ITD. So this argues strongly that transplant is an imperfect solution for patients with FLT3 mutations. And it argues that we maybe should be doing therapy after transplant, i.e. maintenance therapy, which I'll talk about in a minute. So just to finish up some odds and ends here, there are drugs that are very exciting in the relapsed and refractory setting, newly approved, that are giving hope for better outcomes in FLT3 mutated AML. The drug gilteritinib is a more potent and more selective inhibitor of FLT3 than mitosorin. It's a drug that has more substantial single agent activity in the relapsed and refractory setting, and it's largely been developed in that setting and is approved for patients who have relapsed and refractory FLT3 mutated AML, FLT3 mutated at the time of relapse or refractoriness. And that was proven from a study, worldwide phase 3 trial called Admiral, that randomized about 350 patients with first relapse or primary refractory FLT3 mutated AML to either single agent gilteritinib or the investigator's choice of salvage chemotherapy. Patients in the gilteritinib arm who went to transplant could restart gilteritinib after transplant, and there was no crossover on the study. On this study, the response rates in terms of CR and CRh were higher, about twice as high on the gilteritinib arm, and the survival was 9.3 months versus 5.6 months, so statistically significantly improved with gilteritinib. And really, it's the first drug that's been approved in the relapsed and refractory setting for AML based on a survival benefit. So this is an evidence-based recommendation that you screen patients who have relapsed and refractory AML for FLT3 mutations so that you give them the right therapy. And obviously, a drug that's active in that setting, you want to move front line. So not surprisingly, studies that look more or less like what's been done with mitosorin have gotten underway, testing the feasibility of adding gilteritinib to 7 and 3 high-dose Ara-C in maintenance. That is quite feasible, and as you can see on the right, the response rate's quite high. Virtually all patients achieved a CR, CRP, or CRI after, in general, one course of induction, and only 6% induction failure on this study. So very promising results. A randomized trial comparing this to mitosorin is underway both in the US under the PRECOG's leadership and also in Europe under the Hovon's leadership. There's a similar study using another FLT3 inhibitor that's very similar in its activity called crenolinib. Both of these studies are using mitosorin as given on the RATIFY study as the control arm. There's also a fully enrolled study of another highly potent FLT3 inhibitor called quizartinib that's placebo-controlled. Is a little older study, and that should read out soon to see whether the newer FLT3 inhibitors that, again, have more clinical activity than mitosorin as single agents will outperform it in the frontline setting. So just to finish up on a couple of points, I mentioned post-transplant maintenance, and I'll go through this briefly. As I mentioned before, there are patients who have a particularly high risk of relapse after transplant, including patients who are MRD positive going into transplant. But what's unknown is really what the benefit would be for stopping FLT3 inhibitor at the time of transplant, as was done on the RATIFY study, versus continuing FLT3 inhibitor afterwards. Now, if you look at the patients who were transplanted in first remission with no additional maintenance on Ratify, they had a better survival after transplant. And that argues that if you got FLT3 inhibitor with induction, you may not need maintenance. But for patients who didn't, there seems to be a survival benefit of adding a FLT3 inhibitor. And that was tested on the SORMAIN study shown at the top, where 2 years of sorafenib, not approved for FLT3 inhibition, but certainly with that activity, led to better protection from relapse and improved disease-free survival, which was the primary endpoint of that study. And a randomized study of gilteritinib versus placebo has completed enrollment, enrolling patients after first remission transplant. That will read out in a couple of years. Lastly, I just want to show that the current standard for using venetoclax plus azacitidine as the evidence-based low-intensity induction approach has significant activity in patients with FLT3 mutation. You can see that the response rates are higher for venetoclax plus aza over aza alone, and there's superior survival for FLT3 mutated patients. This is the regimen that I use. If patients relapse after it, then I reach for a FLT3 inhibitor. I'm very interested in whether adding a FLT3 inhibitor front line will further improve these outcomes, but we just don't have the data to support that yet. So in conclusion, FLT3 mutations are common and aggressive, but can be chemotherapy responsive and now are associated with better survivals and better cure rates. Rapid diagnostics are key for appropriate use of Mitosorin and other FLT3 inhibitors front line, and more intensive induction, use of transplant, and FLT3 inhibitors all improve prognosis, but at present require still very intensive therapy. We're trying to see whether low intensity therapy with adding FLT3 inhibitors will lead to better outcomes with less toxicity, but that's still very early in its development. And again, gilteritinib at present is an evidence-based recommendation for treatment of relapsed and refractory FLT3 mutated AML. Thanks for your attention.